Dr. Esther Oliva from Massachusetts General Hospital, Howard Medical School, United States. Please welcome Dr. Oliva.
Good afternoon. I hope that everybody had a good lunch. Don't fall asleep now. It's forbidden. In the next 30-35 minutes, we are going to talk about expanding the spectrum of mesenchymal tumors of the uterus. I won't talk about smooth muscle tumors because this morning Dr. Ip did an excellent job talking about those. And I want to start with a clinical history. This was an 88-year-old female with a 6-month history of pelvic pain and altered bowel habits. She had a CT scan of the abdomen that demonstrated a 12-centimeter mass that was arising from the posterior aspect of the uterus, and the question mark, as usually is this a degenerated subserosal fibroid? She underwent radical hysterectomy, bilateral salpingo-oophorectomy, and excision of a rectal nodule. This is the tumor within the uterus. You see this very, large polypoid mass, and it's projecting from the wall of the uterus. Here is the tumor on the microscopic examination. You can see how it is infiltrating the myometrium with these irregular borders. As mentioned by Dr. Philip Eid this morning, looking at the border of the tumors, it may be helpful. This is the microscopic appearance of the tumor. You see hypo and hypercellular areas, and the hypocellular areas are myxoid. This is the high-power magnification. I think is obvious, the cytologic atypia that you see in this tumor. And based on this, the diagnosis was in that of a tumor that was mesenchymal, that was malignant, and then immunohistochemical stains show patchy positivity for desmin, positivity for CD10, and also a strong positivity for PLAG1, which we use it to tell us that maybe the tumor is going to be of a smooth muscle differentiation, especially in the myxoid category. It also had patchy positivity for cyclin D1, BCOR, which doesn't mean much. It was negative for smooth muscle actin, S100, caldesmon, ALK, and ROS. So my colleague signed it out as myxoid leiomyosarcoma grade 2 to 3 out of 3. I wasn't that convinced about the diagnosis, and I actually pursued it, and I sent it to a colleague at Memorial Sloan Kettering, and Dr. Antonescu, and she actually did molecular testing, which at this time we couldn't do it, and there was no PLAG1 rearrangement. But the tumor had GLI1 amplification, as well as MDM2 amplification and CDK4 amplification. So the tumor actually was a uterine GLI1 amplified sarcoma. GLI1 is located in chromosome 12, and it has amplifications on this gene, has been seen originally in carcinomas and melanomas, but you can also have a long list of other tumors that can be showing fusions or amplifications on GLI1. The most known are pericytomas that typically occur in the tongue or stomach or soft tissue, and also the plexiform fibromyxoma or gastroblastoma. But you can see here in this list that other tumors that have a more kind of generic type of name, and they affect other organs, the genitourinary organs and other locations. So this is just one of the newer tumors that can actually affect the GYN tract. And in the largest series of these, most of these tumors actually were seen in males. Most commonly affected the oral cavity, but you can see how they were in the cervix. They have been described in the ovary. They typically had an infiltrative or multinodular growth. Most of them were epithelioid, but some of them also had a spindle cell component. They had a rich vascularity, and as an immunohistochemical marker, they had always CD56 positivity and variable S100 positivity, with variation on other positivity for other markers. And many tumors have, or more tumors had fusions on GLI1 that actually amplifications. And these tumors actually had recurrences, so they can actually be malignant. So just to show you, this is like one of the new kids on the block that can affect the GYN tract. Now, another one that has a myxoid appearance is the inflammatory myofibroblastic tumor, and this is a tumor that also has a varied appearance on gross examination. It can have areas of hemorrhage and necrosis, especially if they are malignant, but also may have a very sticky appearance because they are very gelatinous, very myxoid in appearance, right? And you can see this engrossed in the microscopic examination, and this myxoid pattern can mimic or actually mimics a myxoid smooth muscle tumor. And these tumors in the past were called oftentimes myxoid leiomyosarcomas. This is the most common pattern, but in these areas you can see what we call these ganglion-type cells, which to me is a very helpful feature when I see a myxoid tumor. But there is also a transition of these myxoid areas to more compact areas that kind of start to remind you of a smooth muscle tumor, of a spindle cell type. And in other areas, you are going to see that this is a very compact look, really, really looking like a smooth muscle tumor, and in this particular case, like a leiomyoma. And some of these tumors actually have been confused in the past with leiomyomas, and this may be the presentation in the uterus or maybe the presentation in the recurrence of the tumor. So if you have something that recurs as you think as a smooth muscle tumor and the patient has a history of such a smooth muscle tumor in the uterus, maybe you should be thinking about the possibility of an inflammatory myofibroblastic tumor that actually has this leiomyoma-like morphology. Some of them actually have the appearance of a leiomyosarcoma with cellular atypia and mitotic activity. So you can see how these tumors, were in the past confused with the smooth muscle tumors. And there are even some articles, one coming from the Stanford group, that saying that these tumors were confused with smooth muscle tumors of uncertain or low malignant potential. So all the spectrum of smooth muscle neoplasia. Something that is very characteristic of these tumors is the inflammatory infiltrate. This is sprinkling of lymphocytes, mostly lymphocytes. They can have plasma cells, sometimes neutrophils. And the inflammatory infiltrate may vary from case to case and from area to area. It's typically more common in the myxoid areas, but not necessarily so. There is a variant of these tumors that is not a spindle, but is actually epithelioid in nature, so it's even more difficult to diagnose. It's called epithelioid inflammatory myofibroblastic sarcoma. These are always malignant. Dr. Malpica also has reported some in the uterus. And either in the uterus or in the ovary, these behave in a very aggressive manner. When dealing with these tumors, or when you are thinking about a tumor that is myxoid and is a spindle, you should be thinking, okay, what else could it be besides a smooth muscle tumor? So you have to have in your differential diagnosis an IMT and do an ALK staining. And this ALK staining may show you cytoplasmic and perinuclear accentuation. The staining may be cytoplasmic only, or you can have also cytoplasmic with distinct staining of the membranes. And not necessarily all the tumor is going to be a staining. It may be a staining in some areas and not in others. Sometimes the staining is focal. And if you are not sure, then go and do molecular testing for looking for the ALK fusion. Very rarely, they can actually have ROS fusions. And we used to have a number of morphologic features to try to decide, okay, it's going to be benign, malignant, but I think the best actually of all the articles is this one coming from UCSF that proposed a risk stratification score for these tumors. And it's based on 4 parameters: age of the patients more than 45, size equal or more than 5 centimeters, mitosis equal or more than 4, and infiltrative border. And if you have a low risk, no points, these patients do very well. If you are intermediate risk between 1 or 2 points, then you can actually decide if the patient is going to do well or not. If you do NGS and you find another abnormality on top of the ALK abnormality. And then the higher risk ones are more or equal of 3 points, and those patients are going to actually do aggressively. We also have found that looking at P16 may be very helpful in trying to decide if these tumors are going to be behaving in a benign or malignant fashion. And we saw that when you have less than 1% of P16 positivity, these tumors usually are associated with CDKN1A or less commonly B deletions. And when there is diffuse and strong positivity, they are often associated with third promoter mutations. And when you have a benign tumor, you see just patchy positivity for P16. So actually, P16 can be used as a surrogate marker in these tumors to predict aggressive behavior, especially if you have a tumor with incomplete clinical pathologic information for risk stratification, and also in settings where NGS actually is not available or cost prohibited. So some of you may ask, well, so is that important that I separate, an IMT from a smooth muscle tumor? And the answer is, it depends. If the tumor is small and the tumor has no mitosis and is well circumscribed, it doesn't really matter because the tumor is going to be benign either way, right? But if it's not, that's not the case, then it matters because the treatment will be different for these two types of tumors. Now, moving to the PEComa, or perivascular epithelioid cell tumor. This is a tumor that is composed of cells that have an epithelioid appearance and express both melanocytic and smooth muscle markers. They have been described now all along the GYN tract, but they are much more common in the uterine corpus. Most of them are sporadic, but a certain number of them are associated with tuberous sclerosis. And we think now it is important to recognize these tumors because they can be treated with mTOR inhibitors, except for a variant that is associated with TFE3 fusions. What is the appearance of these PEComas? Well, they can grow in the same manner that smooth muscle tumors with epithelioid morphology grow like. So diffuse pattern, nested pattern, corded pattern. So that's not very helpful in the differential diagnosis. You can also have a spindle cell component, but the spindle cell component typically is the smaller component of the tumor. And when you look at the cells may have clear cytoplasm, they may have eosinophilic cytoplasm, the nuclei may be rounded, may have more or less atypia, they may have pseudoinclusions, and some of them can actually really atypical as the one I'm showing you here. But one thing that is very characteristic of these tumors is the vascularity. And they have this very sinusoidal vascularity, as you see, for example, in clear cell carcinomas of the kidney, right? And this is not the feature that you are going to see in smooth muscle tumors. Among the markers that we are going to use in the diagnosis of these tumors, HMB45 and melan-A are the ones that stand on the top. And HMB45 probably is the best, and typically melan-A is going to show a less positivity and is going to be more focal than HMB45. Now, you have to remember that PEComas can also be positive for smooth muscle markers. So if in your differential diagnosis you have these two tumors, it's not good that you only do smooth muscle markers. You need to add the melanocytic markers just to find out that this could be, in fact, a PEComa. The other marker that has been used is cathepsin K, but that marker was used in the kidney to separate angiomyolipomas that have clear cytoplasm from clear cell carcinomas of the kidney. But in the uterus, you have to be aware that smooth muscle tumors can also be cathepsin K positive, so it's not that useful. These tumors will have typically mutations in TSCS1 or 2. Now, the only PEComa that is different from the rest is the one that is composed only of clear cells. These tumors are going to have actually staining for HMB45, and they actually have TFE3 alterations, but they are not associated with TSC gene mutations or not tuberous sclerosis. Now, we have also seen that when malignant PEComas actually not only have TSC1 or 2 alterations, but they also may have alterations that you see in malignant smooth muscle tumors, namely the presence of p53 mutations or RTRX alterations. So you can see how, for example, this tumor here has on one side a tumor that is very epithelioid in appearance, on the other side is very spindle in morphology. Now, you do the stainings, and you know that the HMB45 and the melanase stain the epithelioid areas, while the smooth muscle markers actually stain the spindle cell areas. So this is why we the group from Memorial came up with this classification of these tumors as mesenchymal neoplasms with myelomelanocytic differentiation. If you have a TSC alteration, then we call it's a classic PEComa. If you have a TFE3 fusion, then it's a TFE3 translocated PEComa. If there is no TSC, not TFE3 or LMS alterations, but you have more than 50% expression of HMB45, you would favor a PEComa. Otherwise, you give a descriptive diagnosis. And this is the same slide that actually Phil was showing this morning, in which we have the histologic criteria that we use to define PEComas that are going to behave, or they can be malignant. And for that, you have to have 3 or more of the following features. It has to be 5 or more centimeters inside, has to have high-grade atypia, more than 1 mitosis per 50 high-power fields, necrosis, or lymphovascular invasion. Otherwise, we call them of low malignant potential. We don't have a category for benign PEComas anymore. So now moving to the category of endometrial stromal tumors, we have actually come a long way from this classification, which is still, I think, stands on the WHO, where we have 4 main categories: the endometrial stromal nodule, the low-grade endometrial stromal sarcoma, high-grade endometrial stromal sarcoma, and undifferentiated uterine sarcoma. If I show you a picture like this, it would be impossible to tell apart a nodule from a low-grade endometrial stromal sarcoma. Both are composed of the same cells, uniform, small, with high nuclear to cytoplasmic ratio, oval nuclei, and delicate chromatin, and oftentimes, they are around the small arterial-like vessels. What it tells them apart is the border of the tumor. In an endometrial stromal nodule, you have to have a well-delineated expansile margin of microscopic examination. There are allowed the presence of focal irregularities, no more than 3 millimeters in size. But what is not allowed in a nodule is the presence of lymphovascular invasion. If there is such lymphovascular invasion, the tumor becomes a low-grade endometrial stromal sarcoma. And this is the classical morphology or gross appearance of these tumors. You see the coalescence of more than 1 nodule, and then you also see the permeation of the tumor within the myometrium. And you have these blue islands. They are kind of sitting in the myometrium and also going into the soft tissues. There is a variant of these tumors that we have recently described, in which you do have a very distinctive whorling of the tumor cells, form these whorls, and the whorls are not around vessels. It's just whorling of the tumor cells, and they are embedded in either a myxoid or fibroblastic background. And you can see here also in the image on the right that the cells actually are not anymore spindle. Now they look epithelioid and start to form little cores. Now these tumors are also frequently associated with this obvious core-like architecture, as sometimes you can see in endometrial stromal tumors. But in contrast to the typical of most of endometrial stromal tumors that are associated with the specific fusions, right? Those don't have the fusions, but they do have actually beta-catenin nuclear positivity, and they are associated with CTNN B1 fusions. characteristic of some endometrial stromal sarcomas. So if we move now to the category of high-grade endometrial stromal sarcomas, this is a tumor. They are tumors that when you look at them, they are not, they don't remind you anymore of the proliferative phase endometrium, but some of them actually may be associated with a low-grade component. They differ from the low-grade tumors because they actually, from the clinical point of view, from the gross point of view, and from the microscopic point of view, and immunohistochemically too. From the clinical point of view, because they actually present at a higher clinical stage, and the patients die more frequently. And the first one that was described is the one that is the YFAM high-grade endometrial stromal sarcoma that is characterized by a translocation between chromosomes 10 and 17. These tumors, from the gross appearance, they look like high-grade sarcomas, and they are fleshy, and from the microscopic appearance, you actually get to see this either diffuse or nested pattern of small epithelioid cells that also have a very characteristic delicate vasculature. Sometimes, as you see in the picture on the right, they even may look like they are forming rosettes. And some of these tumors in the past have been categorized as neuroectodermal tumors. We know now that they are not neuroectodermal tumors within this group of high-grade endometrial stromal sarcomas. From the immunohistochemical point of view, they are completely different from your low-grade endometrial stromal sarcoma. Why? Because they are CD10 negative, they are ER negative, they are PR negative, right? The opposite profile will belong to the low-grade endometrial stromal sarcoma. Now, these tumors are diffusely positive for cyclin D1. Well, we use as a marker for these tumors, right? But it's not unique to these tumors. They also are BCOR positive. And you can say to me, well, but you are showing a picture here that is ER positive. Well, it's ER positive because this tumor actually is associated with a low-grade component that is the component that is ER positive and may help you actually in deciding that what you actually have is a high-grade endometrial stromal sarcoma of the YFAM family. As I said, they are also BCOR positive, which is another surrogate marker of almost all high-grade endometrial stromal sarcomas. This is the second high-grade endometrial stromal sarcoma that we know, and these are the BCOR sarcomas that in the past were confused as myxoid leiomyosarcomas too. They are gelatinous in cut surface, they infiltrate the myometrium, and you can see even from this picture, they are very myxoid. This is a medium power view, how you see how in the past this could have been called myxoid leiomyosarcoma because we didn't know any better. They actually, in contrast to leiomyosarcomas, do have these collagen plaques, as you see also oftentimes in low-grade endometrial stromal sarcomas. They may show palisading. And in contrast to the first group of high-grade endometrial stromal sarcomas, the YFAM, these are not epithelioid, but they are spindle in morphology. So that's also different from the YFAM category of tumors. So if you have a tumor that is malignant, is myxoid, and is a spindle, and is negative for BCOR, which can happen, and also negative, and most importantly, for all smooth muscle markers, and it shows diffuse positivity for cyclin D1, you should perform molecular studies to exclude the possibility of a BCOR high-grade endometrial stromal sarcoma. And so after we knew about these two subtypes of high-grade endometrial stromal sarcoma, now there has been an explosion of new tumors that we think that they belong to the same category. One of them is the BCOR L1. And they are also myxoid in appearance, and they are also a spindle, but they also can have epithelioid morphology. yet another one that has been described by several groups, and one of them is from Dr. Aigami, that is here with us today, and is what we call cat. I say it's different from the cat that you have at home, right? Because these are aggressive tumors. They are cat 6BA. We call them uterine sarcomas. And these occur in a wide age range, but they actually, from the morphologic point of view, they look like low grade. But we kind of want to classify them in the high grade category because many of these patients actually, their tumors behave in an aggressive manner, right? And you can see that from the 39 patients with follow-up, 5 died of disease and 10 were alive with disease, right? And these tumors have been called either low-grade endometrial stromal sarcoma, leiomyoma, or leiomyosarcoma. I think from here you actually can see an appearance that, at least in my opinion, is very reminiscent of a low-grade endometrial stromal sarcoma or tumor. But in these areas here, you start to notice areas that may look like a cellular leiomyoma, in other areas with more spindle-looking, forming fascicles, like a conventional leiomyoma. So you can see how these tumors have been called different names. And when you look the methylation studies, you can see that they are an independent cluster, but they actually cluster closer to low-grade endometrial stromal sarcomas. However, if these tumors have other mutations associated with them, they actually are going to be even more aggressive. We recently have reported another possible subtype of high-grade endometrial stromal sarcoma that has KDM2BA. It's difficult to actually, remember all these abbreviations, right? And we should have real names for those. This is a tumor that, again, is cyclin D1 diffusely positive. These have a myxoid appearance. They actually have spindle cells and epithelioid cells, and the epithelioid cells sometimes form cores, form nests, and even tubules. And we think that actually this could be another subtype, as I said, of high-grade endometrial stromal sarcoma. Typically, they are negative for desmin and caldesmin. As mentioned before, don't use smooth muscle actin in your differential from smooth muscle tumors and endometrial stromal tumors because the latter are often positive. And again, when you do clustering, these actually cluster with the high-grade endometrial stromal sarcomas. There are yet other tumors that actually are, you think that endometrial stromal sarcomas typically more often low-grade, but also have TSC2 mutations, right? And these tumors have a different immunohistochemical profile. They actually, besides being CD10, ER, and PR positive, they actually are going to have expression of melanocytic markers. And they are also having expression of smooth muscle markers, as you see in PEComa, right? They also may have catexin K positivity and PS6, which is phosphorylated S6 ribosomal protein, which is used to predict the response to mTOR inhibitors. How do they look like? Areas look like typical, I would say, on the right-hand side of endometrial stromal neoplasia, but then on the other side, start to be an epithelioid morphology. And this epithelioid morphology may have more the diffuse look like you see here, or may have this kind of corded architecture. And it would be in these areas where actually the cells are more positive for the melanocytic markers. And so these tumors have like this kind of hybrid morphology, right? They actually, not only from the histologic point of view, but also from the immunohistochemical point of view. And because they have these TSC2 alterations, patients may be eligible again for M2 inhibitors, although we don't really know how is going to be the response for them. So it is important that we recognize them now that we have more tools for the diagnosis of these tumors, because it may affect the prognosis and the management of these tumors. And then I would like to conclude with a number of uterine and vaginal sarcomas that till very recently we didn't know how to call them either, right? And we would call them fibrosarcomas, we will call it undifferentiated sarcomas, and some of them belong to what we call now end-track rearranged sarcomas. They typically occur in young women. They typically are diagnosed at earliest stage. They are often centered in the cervix, although you can see them also in the corpus. And they have, some of them have an aggressive behavior. And these tumors were first described by Dr. Croce from France. And these are some pictures that she actually lent me. These tumors have a fibrosarcoma-like morphology. You can see them here around the normal pre-existing endocervical glands. They are also associated with a lymphocytic infiltrate, and commonly they'll have a blunt cytology, as you often see in tumors that have fusions, right? Tumors that have fusion oftentimes have a uniform morphology, as again, Dr. Phil Ip was mentioning this morning. And, as we know more of these tumors, there is variation. Otherwise, it would be too boring, right? So some of these tumors may actually have cytologic atypia. Some of them actually may be myxoid. And they are characterized by positivity for pan-Trk. They also may have a variable positivity for CD34 and S100, but they should be negative for smooth muscle markers, for BCOR, SOX10, so you have to exclude the possibility of a melanoma, and hormone receptors. And now we have a pan-Trk staining, and so positivity will be any positivity, so more than 1%, right? And this is a very sensitive marker, but is less sensitive for when you have NTRK3 fusions, which is the ones that are more common in these sarcomas. You also have to be aware that no stain is perfect, and so you can have a small number of high-grade endometrial stromal sarcomas and leiomyosarcomas that can have pan-Trk positivity. So again, you have to take it, as a whole. And if you are suspicious for it and you are not sure, then you can do molecular testing. Much rarer than NTRK sarcomas are going to be the tumors that are PDGFB rearranged sarcomas that basically kind of look like what you see in dermatofibrosarcoma in the skin, right? And they have this very kind of long fascicles of tumor cells, and they are typically CD34 positive, and they are supposed to be negative for ER, PR, S100, and pan-Trk. But all these tumors basically have the same morphology. They have fibrosarcoma-like morphology. And this is the way we actually, we have learned to recognize them. And it's important, again, to recognize them because they are targetable. That is the importance of the correct diagnosis. And this is my almost last slide. And as we go on and we kind of learn more about molecular, findings, we are describing more and more tumors. I am not so sure how good are we, are splitting so many hairs about these tumors. But recently has been, for example, described these ERBB2 and ERBB3 mutated S100 and SOX10 positive unclassified high-grade cervical sarcomas. Again, Dr. Aigami has been the one on this paper. We have seen actually 3 of these cases, and these tumors will have, they are, are high-grade sarcomas, and they are characterized by S100 positivity, SOX10. You have to exclude the, of course, a melanoma, like in the differential diagnosis. They are also associated often with HER2 mutations and even RTRX also mutations. So it's something that this is a field that is evolving. I have left behind some other tumors because I think maybe they are too esoteric. You maybe even think that these are too esoteric already. But just to show you how this field is evolving very quickly. And so, I think still is very important, the integration of gross morphologic and immunohistochemical features of these tumors. Never use one antibody, use a panel of antibodies, when you are working up a mesenchymal tumor, because otherwise it may lead you to the incorrect diagnosis. You have to also be aware of the overlapping morphologic and immunohistochemical staining patterns that may exist in different tumors. And if the morphology is unusual, or the immunohistochemical profile doesn't fit anything that you actually think it could be, I think molecular testing in those cases would be helpful, in telling you, in reaching the final diagnosis. And, establishing the correct diagnosis is important because, as I have been mentioning, some of these tumors actually are targetable, which is something that we didn't have, a few years ago and may actually benefit our patients. So thank you very much for your attention.
Thank you very much, Dr. Oliva, for the marvelous sessions. As a resident, I feel very surprised and fascinated by your lecture, and I am quite sure my friends feel the same. So on the floor, is anybody have a question?
You cannot ask any questions. You are the one that have described some of these tumors, so you cannot ask questions.
Yeah. Thank you, Esther. Very informative and overview. I think these just entities like the kinase fusion cases, they added some new markers to the routine panel. So we know that NTRK fusion frequently expresses 100. So if it is positive, I will add SOX10. If it is negative, it is very likely NTRK. If it is positive, then these ERB2/3 fusion sarcomas, and indeed, all of them have a very high expression of HER2. So this might indeed be a relevant point justifying separating them for treatment. We don't have the case we reported. Unfortunately, we discovered the exact genotype post-tune, so it was not to the time of life of the patient. She died after 3.5 years. But we don't know if they will respond to Herceptin, for example, or so. So I think that is
the ones that we have, the 3 that we have also are recent. We kind of when we saw your paper, we look back, and some of these tumors actually have been tested molecularly also to, because some of them maybe have been diagnosed as something else, right, as a melanoma of something else, and so all these cases that you may think maybe melanoma, they also have molecular testing, and then you find this, new molecular alterations. So we don't have much information about the follow-up or the treatment on these patients.
I recently tested 2 cases of this PEComa low-grade ESS. I thought indeed it was just a smaller nodule. The outer part is classical low-grade stromal sarcoma. The internal part is a PEComa nodule with very diffuse HMB45. But both cases I tested came back negative for TSC1,
oh, really?
2. Is there any?
We have a series of 8 cases now with Jenny Bennett, and no, we don't. I don't know what to tell you.
But they have the classical F1 fusion. So,
I mean, these cases oftentimes, would in the past would have been called with, low-grade endometrial stromal sarcoma with sex core-like differentiation, right? Can I go now?
Yeah. There's one more question.
Okay.
Okay. I have diagnosed a case of sarcoma in the uterus of the elderly patients.
You had which kind of sarcoma?
leiomyosarcoma.
Okay.
It's her case.
Yeah.
And somehow we had a slot of NGS available. And I just did the NGS on that particular case, and we identify NTRK fusion.
Oh,
So what would you call it? Is a leiomyosarcoma with NTRK fusion, or is it NTRK fusion sarcoma?
well, if it only has the NTRK fusion, I would favor it to be an NTRK sarcoma, you know?
No, but initially it's a typical leiomyosarcoma with the typical immunostains.
I don't know what to tell you. I will let all the people, I mean, I never encountered such case, actually, in my opinion. I never have encountered such case. You know, it's either one or the other. I mean, you can have secondary molecular alterations, right? But if you only have a fusion, an NTRK fusion, I would still think that it has to be an NTRK sarcoma. Some NTRK sarcomas may have some degree of positivity for smooth muscle markers, not to the extent that you would see typically in a leiomyosarcoma. But so in my opinion, but it's just my opinion, you know, would favor an NTRK sarcoma. But I haven't seen the case.
Thank you. She was happy because the patient has access to the drugs.
Okay.
So the clinician didn't care about the name a lot.
All right.
Okay, thank you, Dr. Oliva.